All right, in this lecture we're going to talk a little bit about drug interactions in nuclear medicine. And this is one of those topics where there is not a lot of data, but what I've actually done with this lecture is to kind of to look at an area that we probably don't recognize nearly enough in terms of whether or not it is going to impact the possibility of drug interactions. I don't really feel that giving a line item, you have to memorize 8,000 different things, is worth your time and effort. I mean, in today's society, we are a Google society. You can look up just about anything. So we're going to talk more about kind of general topics and kind of a broad overview of drug interactions. We're going to focus actually on herbals because as a pharmacist, this is the area that I know that a lot of people don't pay a lot of attention to, and I would imagine as you go through this process, no one has really talked to you much about herbal medications either in terms of drug interactions. And then we're going to talk a little bit about some examples of where certain drugs and things do actually interfere with nuclear medicine studies. So that's kind of the summary of what we're going to do today. Let me start off with the definition, because I think sometimes people get a little too tied up in words and don't really realize what we're going to be talking about here today. When I talk about a radiopharmaceutical drug interaction, the idea of a drug interaction is some kind of a interaction between your radiopharmaceutical that you've administered and a drug that actually alters the biodistribution of a radiopharmaceutical. Now, it is of concern because it may interfere with the interpretation of the nuclear medicine studied, obviously. The types of things you might see, it may actually cause some weird uptake in the desired organ system. So you still see the organ system you want, you just see either more or less than what you would anticipate or what you are expecting to see based on the patient's physical characteristics and their current disease state, which could make you obviously misinterpret the function of that particular organ. It's obviously possible it could get taken up in the wrong organ or tissue, and so unfortunately, in some cases, uptake in a wrong organ or tissue is an indication that there's something else going on with the patient. And so it's difficult to determine if this uptake in the wrong organ or tissue, if it does occur, it'll be difficult to determine if it's because there's something wrong with that organ or tissue, which leads to a whole bunch of extra testing for a patient, or if it's because they were on this particular drug and nobody caught it before it actually happened. You could actually increase the excretion of radiopharmaceuticals or we could make it stay in the body longer than what we had anticipated. And since most of what we look at is functional, this could totally change the outcome of our particular study. Obviously, any of these kind of things have potential impact. Obviously, the study itself, it can, completely tank it. But it's also important that sometimes we use drug interactions for a good thing. Think of a lot of the non-radioactive pharmaceuticals that we administer in terms of nuclear medicine studies, Lasix in renal studies, and cholecystokinin in hepatobiliary studies. Sometimes the interactions are not all bad, and so we intentionally create drug interactions all the time in nuclear medicine. And there's a lot of things that we do this for. I mean, think about most of our actual known drug interactions that we use. We can decrease radiation dose by getting the patient's the drug out of the patient faster. We can cut down on camera time. I mean, there's a million things that we do, and the reason why we do that. So a drug interaction is not always a bad thing. Most people walk in and say, oh, drug interaction is terrible. There are bad ones that can change how we approach things, but there are also good ones, and we use good drug interactions a lot in nuclear medicine. The key is being able to figure out in the patients who walk in the door, which patients are actually on medications that potentially could change the outcome of our study. Because for the most part, most of the drug interactions that we don't know about, that we're not intentionally giving to the patient, have the potential to negatively impact our study when we look at it. And this is one of those things that, as a pharmacist, this is one of my big areas is, I am all about looking at every prescription that the patient takes and trying to figure out if and when that might be a problem. But you're not, and that's important to recognize. You cannot memorize every potential drug interaction. You cannot actually identify every potential drug interaction. I mean, there are a lot of them. Not every patient who gets an MDP, for example, is going to be on drug A. And so, for the 4% of the population who happens to be on drug A and getting an MDP at the same time, those are hard to track down and to figure out. So this is not an easy area to talk about because there's not a lot of data out there that's going to give us a lot of information about, basically saying this is going to happen if. Because there's just not enough patients to form a nice, strong statistical validation that that's actually what happens. But we can look at a lot of drugs and drug therapy and make assumptions based on how they work to decide if and when they may or may not interfere with your nuclear medicine study. And so ideally, every patient that comes in should have a review of their drug list. Now, I know what happens because I've seen it in the various institutions I worked in. We do medicine reconciliation, and a lot of times medicine reconciliation is giving a piece of paper to a patient and saying, please write down all the medicines that you're on. And, for some patients, that's not a problem. I'm on, this drug, 10 milligrams twice a day. I'm on this drug once a day at bedtime. That's great. But I have seen a number of med lists that say the white pill in the morning, the blue pill in the afternoon. I mean, your patients are not always going to be the best reporter of information in this particular area, and that's unfortunate. But there's not a lot that you can do about that either. So the point of what we're going to talk about today is, not to make you pharmacists, not to make you pharmacognoscists. It's basically just to give you some things to think about when we are looking at patients walking in the door and in response to their potential drug therapy and how that drug therapy is going to actually potentially impact the nuclear medicine study. So as a pharmacist, I'm always all about drugs. So the key, though, that I always like to bring up, when you ask a patient about their drug therapy, almost every one of them will tell you their prescription pharmaceuticals. I take drug A, drug B, drug C, here's all the doses, blah, blah, blah. And they're all things that you walk up to a pharmacy counter, hand a prescription to a pharmacist, and get a pill in the nice little fancy prescription containers like you see at the top of this slide. But what people don't always remember, over-the-counter medicines. People take over-the-counter medicines all the time, and very few people think of them as drugs because you can buy them yourself. And so when you ask people about, can you tell me what drugs you're taking, they automatically go right to their prescription list, and they will tell you that. But that's not the best question to be asking. What kind of pharmaceuticals are you taking? Prescription or over the counter? And basically they can, sometimes they can answer that question, sometimes they cannot, because again, they don't think of them as actual drug therapy. Now, the other thing that is really problematic are herbals, and that's what we're going to focus on today. And I'm sorry you can hear my phone ringing in the background. But talking about herbal medications, herbals are one of those things that very few people actually like to talk about. But let's start with prescription drugs. As I said, the patient's going to be the most familiar with these agents, but they are most likely going to call them drugs. The things that you want to think about, are the meds current? We did a review back at Wishard, and it was surprising to see how many people were on Lasix and furosemide. And if you don't recognize that, that is the same drug. So you are not going to be on both Lasix and furosemide. You may have gotten a prescription for Lasix and then switched to the generic furosemide, but if it didn't come off your med list, it looks like you're taking it twice. And as I mentioned, some of your patients are going to be, it's the blue pill and the red pill and blah, blah, blah. I know some nuclear medicine departments ask the patients to bring in a drug list with them when they come. The big push in pharmacy is to try to get everybody to have a standardized medicine list, but that doesn't always happen. So, if you can get at least an idea And it's not so much that we necessarily want you to look at them and be able to say, uh-oh, this is going to interact. It's actually more important when you get something on the back end that doesn't look right, because one of the first questions I would ask is, okay, what drugs were they on? And because that could very well be a source of the problems. So, we don't want you to look at them and necessarily make broad judgments about drug A, drug B, and drug C, but if you can get a list of drug A, drug B, and drug C, and we see a problem, it's a great way of going back and trying to see if that is a potential place where it interacts. And then you get somebody like a pharmacist involved who can say, here's the mechanism of action of this drug, and if you know what the mechanism of action of the distribution of your radiopharmaceutical is, you can see if there's going to be some places where there might be an interaction. Again, we're going to talk about reporting because I've mentioned it before, but, if you have one that you strongly suspect is going to be a drug interaction, you should probably write it up, because most people don't. And so, while I may have a drug interaction between prescription drug A and radiopharmaceutical B, maybe 40 other people had that same interaction, but nobody took the time to write it down. And that's why drug interactions for us are so difficult to try to figure out. We base most of our drug interactions on the mechanisms of actions and how they're going to behave in the body, and then try to determine if there is a possible interaction between that. And then we have a few cases where we've demonstrated it, but proving causality is not something you can do in a single nuclear medicine study. You need to see that response several times in order to say, yes, I bet it's from that drug interaction. And so, unfortunately, we just don't do a very good job usually of documenting all of this kind of stuff. As I mentioned, over-the-counter or non-prescription medications, most patients don't consider these to be drugs, and so most of them will leave them off of their drug list. The other thing is people misuse these agents all the time. Hey, Tylenol, it's on the counter, so I know it says take 1, but if I take 4, it probably will be okay, because it's over the counter, and they wouldn't give it to me if I was going to harm myself in any way. That is not the case, and quite often there are some things in a over-the-counter drug that could interfere with a nuclear medicine study, and if the patient doesn't mention it, we missed it. I wanted to talk about herbals because I think this is one of those areas where most people just are completely lost. And I'll tell you, when I was in pharmacy school, this was not an area that we covered. And when I took my pharmacy boards, there were 10 questions about vitamins and herbals. And I basically just looked at them and said, oh, I'm going to have to totally skip those because I don't know them. Herbals are not easy. And again, it's not that we want you to memorize 18,000 herbal drugs, because I think there are pretty close to that many, and try to be able to make assumptions about them. But asking the patient the question about herbals, are you taking anything that is herbal, natural product, vitamins, whatever, is a great thing to make sure that you have on the drug list. Because every so often, and I'm going to show you some examples today, this will pop as being a potential interaction with a radiopharmaceutical. So let's talk a little bit about herbals, though, before we get started. What is an herbal? By definition, if you actually look at the definition of herbal, any plant or plant derivative that is used as a medicine to treat or enhance performance or function. And we'll come back to treat in a few minutes, but basically, that's what these drugs are designed to do. Sometimes you'll see the terms natural remedy. That also could include animal or mineral derived substances. They're not necessarily plant only. But the interesting thing about herbals is it is the most non-regulated or under-regulated area of drug therapy. And some of you probably know people like this who basically herbals and, herbal and vitamins and things like that are people's entire medicine regime. They do not use traditional medicines. They go entirely into herbal medications. And, and that's fine, because for some people, and there's some reports that these are effective drugs. But if you don't ask about them, you're not going to write them down. And again, we have to make sure that we do that. When we look at how herbals are made, you can walk into GNC or any of those kind of stores and you can find 8 million different herbal-based products. And they're all different. And one of the things that I find the most interesting about herbals, so this nettle herb is a dietary supplement that you can buy at GNC or whatever. Nettle is Urtica dioica, which is a nice source of chlorophyll. It's basically just a green plant. But this is what actually came off of this bottle in terms of what it does. Nettle helps provide strengthening and support for allergies, chronic inflammations, excessive mucus drainage, ulcerations of the mucous membranes, burning and difficult urination, hemorrhoids, a swollen prostate gland, arthritis, gout, gas, colic, lactation, psoriasis, profuse menstruation, pregnancy, postpartum, libido. So basically, this is a miracle drug, in case you didn't realize that. And that's kind of one of the fundamental problems of our herbals, is that there's not a lot of strong scientific data. Somebody takes nettle herb and says, man, after pregnancy I was so depressed, but I took this nettle herb and I felt so much better. Boom, it's now postpartum. So because it is unregulated, or not nearly as regulated, but they are natural products, so they should be safe. The Food and Drug Administration basically does not spend a ton of time looking at specific production for herbals. And if you'll notice on every herbal that you would pick up that is considered to be an herbal medication, there is a statement somewhere on the packaging that very clearly says these statements have not been evaluated by the Food and Drug Administration. This product is not intended to diagnose, treat, cure, or prevent any disease. And so you think, well, who in the world would use them? And when we actually did this talk originally, it was kind of amazing to me, because I did not realize I knew the extent, but I didn't realize the extent. It is estimated that almost half of the American population uses one alternative treatment, and alternative in our case is considered herbals, not traditional prescription drug medications. 1 in 5 Americans on prescription drugs also take herbal remedies or supplements of some kind. The one that really surprised me, almost 50% of pregnant women took herbals during pregnancy, because they immediately say, herbal, it's natural, you sell it on a shelf at a store, it has to be okay for me. The other interesting one, 70% of patients do not disclose herbal use to their primary care physician. And there's a variety of reasons. One, because most people don't think of them as drugs, so they don't even talk about it. But the other thing is some people actually are trying to hide it from their physician, because they think that the physician might think that they're a weirdo, or that they're, kind of off their rocker for using this, so they just don't talk about it. And I should probably mention in here somewhere, I don't have a problem with most herbals. I mean, I think if they make you feel better, if you feel better when you're taking them, unless it's causing some kind of physical harm to you, who cares? It shouldn't matter. But I also know that some of these things are going to interfere with your nuclear medicine studies, and so it's important to make sure that you know what's going on. So the other interesting facts in this process, usually your 36 to 49-year-old age bracket is where most people use them. That's most of the time related to some of these other things. College-educated individuals, women greater than men, and use in households where income is $50,000. If you actually go to a lot of these places and take a look, some of them are expensive. And if you want to use these continuously, they get very, very expensive. And so usually when we say older people are using them, it's because they're starting to get into that age group where they're going to start needing medical therapy of some kind. And so their alternative is to try the natural stuff before they actually get into the real drugs or the prescription level drugs. And so, these are the patients, a lot of these patients are the patients that you're going to see in your institution. And again, it depends on where you see them. But this was probably the most interesting fact. 86% of Americans believe natural supplements are safe. And for the most part, I would agree with them. However, that's not always perfect. The FDA, while they don't do extensive regulation of herbals, do take action whenever there is an herbal or a product that looks like it may be impacting patient safety. So, for example, we used to have herbals that had iodine in them. years ago, and that basically was stopped by the FDA because of the people were taking that particular drug thinking, oh, we take iodine, we stimulate thyroid hormone production, I'm going to lose weight. So it was a very common supplement in weight loss drugs. But it also disrupted your thyroid hormone synthesis. And so given that that is an essential component of life, the FDA basically stepped in and said, we can't just have people randomly taking this. And so, for the most part, the herbals that are on the market are safe. For a pharmacist, we're most concerned because some of the herbals will interact with prescription drugs. And so we like to know that piece of information to make sure that, the herbal's safe, but not in combination with this drug that you're taking. Or, the herbal is safe and the prescription is safe, but the herbal changes the metabolism of the prescription in such a way that it no longer becomes safe. There's a variety of different things that might happen in that process. The herbal drug market, you're going to be surprised when you actually ask this question because a lot of your patients will be on herbals. It is estimated, this is from about 5 years ago, that about $3.5 billion a year were spent on herbal medications. And that's not including vitamins, supplements, minerals, supplements, things like that. I mean, this is a huge market. And so you're not going to see herbals going away anytime soon. They are still going to be around, and you're still going to see patients on them. And if we can sell these patients into thinking that this is a cure that's going to help them or make them feel better, they'll keep buying them. A lot of patients probably are fully aware that some of these drugs may not be as efficacious, but they're afraid of prescription drugs or they're nervous about starting prescription drugs. And so they'll try these herbal medications to see if it makes them feel better. And, and sometimes they do. So you need to be aware that your patients are going to be on these kinds of medications, and you should always be asking. So to give you some ballpark numbers, and again, to focus on why I don't think that you need to memorize a lot of this information, there are more than 13,000 prescription drugs on the market today. My job is to learn about prescription drugs, and I can tell you I cannot list the 13,000 drugs that are on the market today. That's called reference material, and we all use it. There are more than 76 different approved non-prescription combinations, and that's not standalone. That's just, this plus this, and this plus this plus this. And so, there's a lot of stuff out there. And I've already mentioned, with herbals, we have absolutely no idea. I mean, there are so many different types in this combination with this combination and stuff like that, that it's very difficult to keep track of everything. And so the premise of the rest of this talk is don't. I don't think you should. I don't think you should try to. I think you have people, the pharmacists in your institution, whose job it is to help you figure these things out. But again, if you don't have a documented list of what's going on with the patient, I can't relate this, or I can't rule prescription interactions out or drug interactions out if I don't have a good list. And you're the front line with the patient. I mean, this is the kind of thing that you can try to figure out and try to clarify and to make sure everything works well. The problem is you clarify on the front end before you actually identify a problem. And so I know exactly what happens. We're all busy. We've got 80 million things going on. And so most people don't do that. They basically just say, okay, well, we're, the 1% of our patients who are going to have a problem, we'll try to catch them on the flip side. But if you can kind of start thinking about this in terms of your practice, it makes things a whole lot easier. So let's talk now, shift over to nuclear medicine. Today I'm going to cover a number of interactions, but I am not covering anywhere near as many. 10 years ago when I gave a talk similar to this, I asked you to memorize a whole lot of things because you just had to. Today we have Google, as I mentioned. If you think that there's a possible problem, we Google it. But as I also mentioned, if we don't document these things and make those documentation available to the public or to other healthcare practitioners, you're going to Google and find nothing. So when you have abnormal studies, when you have problems, do not rule out drug therapy, prescription, over-the-counter, or herbal as a potential source of your error. And, and if we do find these things, it's important that we talk about them and that we get that information out. We're not saying that it definitely caused, but if all of a sudden I have 12 papers that say this was a potential problem, I'm going to be leaning more closely towards, yeah, that's probably a problem, especially if it's exactly what I'm seeing in my patient that I'm dealing with. So please do not spend any extensive period of time trying to memorize this kind of stuff, because I think you should recognize these things, but definitely not memorize them. Quite a few of these you're going to recognize anyway, because we cover them as part of a typical study. So, for example, cardiac imaging. There are a lot of things that are going to potentially interfere with cardiac perfusion patients. First off, if they're coming in for a cardiac perfusion study, they're having some kind of cardiac problem. Most of them are being treated for some type of hypertension. Beta blockers, nitrates, calcium channel blockers. The problem with all of these drugs is that they're either going to prevent the patient from actually exercising and getting to full stress. Some of them are going to interfere with your pharmacologic stress agents and prevent you from reaching your maximum heart rate or your maximum stress level in the heart. Some of them have been shown to actually decrease the number or the size of a stress defect when you actually see them on a nuclear medicine study, which means that we could totally miss something while we're trying to read the scan, and that leads to false normal stress images. So all of a sudden I missed a defect and I call my stress image normal in a patient who has a viable defect that could be fixed. As I mentioned, we've done this before several years ago back at Wishard, and we looked at the cardiac medication profiles in patients who showed up for nuclear medicine myocardial stress testing. And we looked at 507 patients, and just to get a feel for how these patients presented. And you can see the demographics here. 54% of them were on a beta blocker, 35% were on nitrates, 25% of patients were on calcium channel blocker, and 25% of patients were on some sort of asthma therapy, whether that be albuterol, short-acting, long-term steroid type of therapy. But the thing that was really interesting for us, 64% of those patients presented with medication profiles that didn't match hospital records. So basically, they were asked to bring in or have documented their cardiac or their medication profile. And then we went back to the hospital record and actually looked up their drug profile there, and they don't always match. So I know a lot of people will say, well, we'll just go to the chart and see what we can find. Not always your best idea. And your chart doesn't include herbals. They don't include over-the-counters. And so it's important when you are looking at this kind of stuff, do not rely heavily on the chart. As difficult as it is sometimes to get information from your patients, the reality is the patients are going to have a more complete idea of what their profile is than the last time they came into the hospital, more times than not. The other thing that was interesting for us, and this is why we approached this particular study, because we know that drugs interfere with pharmacologic stress testing, and that's what we were looking for. And you can see that almost 90% of the patients were getting pharmacologic stress as opposed to exercise stress. And so the potential for drug-drug interactions here goes up quite a bit because they're getting two pharmacologic agents in this process. So obviously the ones that you are most familiar with here, pharmacologic stress with either adenosine or dipyridamole. We can now also say Lexiscan on this list. Basically, the idea here is to create vasodilation through binding of adenosine at the receptor. The biggest interaction, methylxanthines, theophylline, caffeine. And I see attached lists for caffeine composition, but since I'm not physically there, this is a list that you could actually easily find on the web. Just Google caffeine content of substances, and there's several very nice websites that give you an approximate list. So that's not hard. All of you ask, well, are you on caffeine? Have you taken, when was the last time you had coffee? Theophylline isn't used all that often anymore. But again, I'm trying to pull out some weird instances to show you that this is not as easy as possible. So the item I have up here now is this drug called guarana. And guarana is a vine that's actually indigenous to the Amazon basin. And a lot of times we will crush up the seeds of this and use in herbal preparations. And it's used for things like enhancing athletic performance, weight loss, treatment of diarrhea, decreasing fatigue. You kind of get the feel from those lists of things that it is a stimulant type of medication. And it is, because guarana is essentially caffeine. When we talk about coffee beans and we ground up coffee beans, about 1 to 2% of the mass of a coffee bean is caffeine. With guarana, crushing it up, about 3 to 5% is caffeine. And so 250 milligrams of guarana seed is equivalent to about 90 milligrams of caffeine. And so, you've got these people that are taking guarana. You walk in the door, they didn't have any coffee, but they took 1,000 milligrams of guarana this morning because they've been feeling kind of run down and they're really tired and they just needed a little pick-me-up. Well, they got one with a whole lot of caffeine. And so if you're going to try to cardiac stress these patients, and again, cardiac stress patients, a group of people who are probably feeling pretty lethargic and run down and stuff like that, this potentially is going to change the outcome of your study. Ginseng is another one. Sometimes ginseng, the big seller for ginseng is increased concentration, stamina, or increased erectile function, increased athletic performance, and anti-stress. And it's not so much that the ginseng is the problem, but what we'll see a lot when you look at these herbals is they may have ginseng in them, but they will also have caffeine or guarana as secondary ingredients. And so they're not always listed on the front. The drug they're taking is ginseng, but what they're getting is ginseng with a kick. And again, another hidden source of caffeine or guarana is in some of the combination products. And like I said, ginseng is one of those big ones. The other type of thing from a cardiac perspective, when we talk about MUGAs, is you can actually have some interactions with herbals in terms of the labeling step, where you can actually lead to difficulty in labeling the red cell. And so there are several things that prevent the technetium from crossing into the red cell or crossing the red cell membrane, which basically leads to a whole bunch of free pertechnetate. The type of things that we always worry about or that we warn you of, heparin, you can actually form technetium heparin, so that takes the technetium out. It has nothing to do with whether or not it can cross in and out. Patients that have recent blood transfusions may have some increased free hemoglobin because the infused blood that we're giving them may have damaged red cells, which is actually liberated hemoglobin. And if you're doing this, especially as you're looking at these transfused patients, we're going to bind to hemoglobin. And so if you have a lot of free hemoglobin in your blood sample and you try to label it, you're going to label the hemoglobin that's outside of the red cells as opposed to in the red cells, which can lead to increased uptake in the liver because that's where it's going to be scavenged out. Iodinated contrast media competes with the BAM3 ionic transporter, which basically blocks the movement of technetium into the red cells. And dipyridamole inhibits the ionic transporter as well. And you think, well, what difference does it make? We don't give persantine while we're doing stress studies, but a lot of the newer anti-clotting mechanisms, medications actually contain dipyridamole as part of the anti-clotting cascade. So while you're not giving them dipyridamole, they may still be taking dipyridamole, and that can actually explain why you see some weird stuff on your red cell studies. In terms of biliary imaging, obviously we know there are a million different things that actually interact with the function of the gallbladder. Narcotics, where they constrict the sphincter of Oddi and increase the backflow into the hepatobiliary system, which basically can show up like it's not dumping, which could look like a blockage. Nicotinic acid, we don't use that terribly. TPN, we already know about gallbladder stimulus. But when we look at the narcotic analgesics, keep in mind that these are not all exactly the same, but I think a lot of people, if I said codeine, you're like, yep, narcotic. If I said morphine, narcotic. If I said pentazocine, you might not recognize that. And so, having these kind of lists around when you actually are doing drug searches where, patient coming in for hepatobiliary, have a list like this that basically says, okay, if any of these show up on that patient's list, I should be concerned. Iodine, we know there's a bunch of stuff that interacts with iodine as well. And I give this every so often just to kind of drive home a point. When we talk about iodine uptake, you are basically trying to compete with a radioactive iodine molecule for uptake in a thyroid. And so, we do iodine restrictions in these patients to try to minimize the iodine blood pool. But sometimes it's nice to give you some numbers for scope. You have to have at least 150 micrograms of iodine every day so your thyroid will function. That's how much, the minimum amount of thyroid hormone you need to actually have a functional thyroid gland. The average adult in the United States takes in between 300 and 500 micrograms. So you basically are 4 times higher than that at minimum, or at maximum. So basically 4 times what you need. Now, and that's not including people who go a little crazy. People in kelp and iodine supplements is kind of the focus of this. Most of these things contain between 150 and 1,000 micrograms of iodine. And so a single pill is going to almost increase by tenfold in some cases how much iodine you have in your system. And so, when these people are taking these supplements every single day, their iodine blood pool is going to be considerably larger than what you are estimating. And that's why this stuff interferes with nuclear medicine studies, because you're trying to compete for iodine uptake with this huge blood pool. I threw 1 gram of iodized salt on there just to give you some perspective. Even that, when we salt our food, if you're using iodized salt, you're getting a significant amount of iodine, considering how some people salt their food. And then lastly, just to give you some perspective, we could show you how to calculate this, but I did it for you. To give you some idea of when I talk about how much iodine, the actual iodine, is in a therapy dose or a diagnostic dose, a 200 millicurie I-131 therapy dose is usually only about 1 to 2 micrograms of iodine. So I am now taking that and competing with 1,000 micrograms in the bloodstream. You can see why we do iodine restrictions, because we want to lower that iodine blood pool as much as we possibly can and maximize the chance that when the iodine is grabbed out of the bloodstream by the thyroid, that it's going to be taking a radioactive version, not a non-radioactive. And you can see on there our diagnostic dose of I-123 is considerably lower than that. So that's why most people spend a lot of time talking about iodine interactions. And I'm not going to, because we've covered this a million different places. But cough medications, when we talk about drug therapy, don't rule out over-the-counter products, because although we don't do this nearly as often as we used to, excuse me, most of today's medications, we do not have a lot of iodine in them. But combination products where, like, for example, we had dextromethorphan and iodinated glycerol as an antitussive expectorant. We had a patient that came into nuclear medicine when I was on my clinical rotations that was so hyperthyroid, I don't even know why we studied her. She was that hyperthyroid. I mean, she couldn't sit still. Her eyes, she was just all over the place. And she did her study, and she came back with like 4% uptake. And we're like, wait a minute, that's not right. That cannot possibly be correct. And so we went back to her med list, looked at it, looked fine. There was nothing on it. And so finally, we sat down with her, and we started asking about other things. And when we talked about cough medicines, she's like, oh, I've had this terrible cough for the last about 6 months. And well, how are you treating that? Well, I get some cough medication from the pharmacy behind the counter, and it's worked like a charm. And so she was chugging sometimes 1 or 2 bottles of cough medicine every day for the last up to 6 months that contained iodide. And so her iodide blood pool was so large that's why she had no uptake. She did a iodine restricted diet before she came in. She thought she did everything she was supposed to. She didn't realize her cough syrup had iodine in it. Now, while you should be a little more concerned about the fact that she was taking iodine or cough syrup for 6 months and not getting that worked up, we did take her off of the cough medicine, had her come back, and her percent uptake jumped up to about 78%. So it was most definitely an interaction. So I've mentioned kelp. This is the trigger word, because again, most people aren't going to immediately, if they are taking the herbal kelp, they're not going to recognize iodine. This is not, as I mentioned earlier, where we talk about the iodine supplementations. Kelp is seaweed, and seaweed is in the ocean, and in the ocean there is salt water, and they tend to have a lot of minerals as a result of that. And so that's part of the health benefits of this particular herbal, is that you've got potassium and magnesium and calcium and iron and a whole lot of iodine. And so, again, per capsule, you may get up to 1,000 micrograms of iodine. And kelp is one of those things where people are like, oof, one's good, 4 is going to be better. So these patients tend to definitely have a little bit more than what we anticipate. And most of you are aware of that. We talk about that quite often when we talk about iodine. But here's the other one. So this is a herbal, or a algae, that is actually called bladderwrack. And it's a form of algae, which means that it generally grows in the same environment as kelp. It contains between 10 to 15 pounds of iodine per ton, which comes out to about 60 micrograms of iodine per capsule. So it's not as big as what we would normally think of with kelp, but again, it's used as a weight loss supplement. And so a lot of people in the weight loss world, if 1 is good, 4 is better. And so all of a sudden, 60 times 4 equals 240 times 7 days a week times 6 months equals an awful lot of iodine that you have to deal with. Bladderwrack is actually found in a lot of combination products as well, and again, a lot of people don't recognize it. These were some of the few that I found, and if somebody comes in and says, I'm taking Biomark for weight control, you would never know that. Celicine, Dermalife Patch, Slimmin' Up, Elusan Cleaner. And again, my phone is ringing, sorry. But, unfortunately, if somebody gives you these numbers, you just have to look at it, and you may have to go and actually look it up to figure out what's going on. Now, you think, okay, well, all of that's going to interfere with iodine. Another one that actually messes with it, you think of that because it's like, ooh, it's iodine. That makes sense. This particular herbal, lemon balm, is a member of the mint family. It actually has been shown to lower thyroid activity. And one of the things on its list is the treatment of overactive thyroid. And it has nothing to do with iodine. This particular herbal binds with thyrotropin and the thyroid stimulating hormones to prevent stimulation of thyroid receptor sites, which basically decreases the amount of iodine that's actually taken up. So there are many things in that world that can interfere with thyroid imaging. So that's one of those areas where identifying herbals and other medications is essential. MIBG, we almost exhaust this, even though it's not a common study anymore. You don't see a lot of adults coming in for pheochromocytoma studies. We do use a lot of neuroblastoma patients, but we also assume that a lot of these neuroblastoma patients are not going to be on the type of drug therapy that we would anticipate would interfere with MIBG. I would say MIBG by definition is the most likely candidate for having some kind of a drug interaction. And you can see I've got several mechanisms here listed because there are a variety of different ways that this actually works. This also has an incredibly long list. Again, I would have normally given you an attachment 5 years ago, but today it's just as easy to Google it and look it up. Ideally, and the problem with this particular one is, especially if you're doing a pheochromocytoma patient, a lot of the patients that are coming in are going to be on cardiac meds, and a lot of the meds that are on this list are cardiac in origin. The other one are the antipsychotics and the antidepressants. And so while we would very much like to hold their medications for 2 to 3 weeks to make sure everything is cleaned out of their system, there are a lot of these meds that just cannot be withheld. I am not pulling a patient off of an antipsychotic so I could do an MIBG study. We're either going to do something else or we're going to try to figure out how to make it work. But it's a pretty long list. But I want to show you, just because this is another one of those cases that I actually saw, just so you get a feel of what a drug interaction may actually look like. So this is a normal MIBG study. You can see some salivary glands, you see the liver, this patient's heart is showing up, and you can see some bladder in there as well. But, at this point in time, this is what I like to see. And, obviously in this case, we were looking for a pheochromocytoma, which really didn't pop in this particular case. And so that's what you expect to see in a neuroblastoma patient. This was a patient that we actually saw at IU. 48-year-old female who presented with a possible pheochromocytoma, and they wanted to evaluate location. It turns out that she was being treated with one of the newer generation calcium channel blockers at the time, and the resident who did the review of the medications did not recognize the name, nor did anyone else in the nuclear medicine staff. And so the biggest reason was they didn't really have an up-to-date listing of medications that interfered with imaging. And so the patient was given I-123-MIBG, brought back 24 hours later to do some imaging, and this is what they saw. And if you think back to what I just showed you, and I'll show you a comparison here in a second, this looks nothing like what you expect to see. You see a nice hot liver, but you see a lot of muscle. I don't see any heart. It just did not look right, and it wasn't right, because basically we didn't even match the normal distribution pattern. And so after this study, we went back, pulled the med list, and in consultation with pharmacy staff, recognized that there was a calcium channel blocker on board, which is on the list. And so it turns out that that is a perfect example of a drug interaction that was related to the administration of one of the drugs that was actually on that list. Now, they actually discontinued the calcium channel blocker, brought her back in a couple of weeks, and we had a very nice pheochromocytoma that actually lit up after the fact. So, so she definitely had a pheochromocytoma. It just wasn't evident on that study because of the abnormal distribution. The next thing I have on my list is ephedra, and I use this on here even though we have really removed most of the ephedrine and pseudoephedrine in our armamentarium of drug therapy. You'll still see some people who are on it from a prescription perspective, but you used to find this stuff in herbal medications all the time. And the idea was it was kind of like an anti-asthmatic. It helped stimulate the central nervous system so you felt better and you felt fresher and all of that kind of stuff. You can't really walk into an herbal medication store anymore and pick these up because this is one of the ones the FDA tagged as being inappropriate or unavailable for herbal use. But if you haven't found out about mail order pharmaceutical marketing, go type in the word ephedra and see if you can find it somewhere. There are a million different places where you can buy this, and the number one reason why most people used it was weight loss. And so you have a very large population of people who want to lose weight, who will search this kind of stuff out. They'll go on vacation and they'll bring it home with them. So even though it's not really commercially available and it's not going to be a common thing that you will see, I left it in here because you still get some people that search it out. That whole weight loss claim is a pretty impressive claim. From the skeletal imaging standpoint, I have a list here that you can take a look at. Several drug-related things in here. Long-term steroid use is going to actually have a global decrease in bone density, which decreases the uptake of your tracer in the bone. Anything that has a high aluminum content, you can actually chelate the alumina and the phosphate in the MDP, and that chelation, that's a normal chelation, phosphate and aluminum. And so basically what happens is you form a large complex that is going to be scavenged out by the liver. And so if you see a lot of uptake in the liver, one possible reason is they have an elevated blood aluminum level that you should be looking for. A lot of the iron-containing compounds, some of your chemotherapy stuff is going to interfere with the kidney. It's not so much that that's a drug interaction with the radiopharmaceutical itself, but it is a drug interaction with a physiologic process that potentially can decrease the outcome of your particular study. And then the last one on here is the one I'm focusing on. Estrogens. When you give a woman estrogens, you tend to increase proliferation of the mammary cells, and sometimes we'll see some calcification, and it's actually not uncommon to have bone tracer in the breast. And you can see here this woman, she was actually coming in to evaluate metastatic spread of breast cancer, but you see that shadow on her left-hand side that you don't see on her right, and that's because the left-hand side is the original breast that was left in place. On the right-hand side, she had a mastectomy and actually had that removed. And so it just looks like a shadow like that, a pretty diffuse uptake, but that is a drug interaction with with estrogen. And so something that you should just kind of keep an eye on. Gallium, the last thing I have really on the list for drugs, gallium, there are a million things that interfere with gallium. And again, I used to give you a list, but at this point, I'm not asking you to memorize that, so it's not important. You could easily Google that. And the other reason is you use gallium so infrequently these days. I mean, this particular image was a patient with lymphoma. And obviously most of the patients now are going to be getting PET scans in that area where we don't have to worry about them. But gallium is another one of those places where we have a lot of potential interactions. Oh, sorry, kidneys. I guess I didn't realize I wasn't quite done. Kidneys, our kidney agents, again, DMSA and PEDS, aluminum, bicarb, mannitol, captopril. Again, we use this probably most often in PEDS, and most of them are not going to be on any of these kind of medications, but these are recognized drug interactions with DMSA. MAG3, ACE inhibitors and angiotensin receptor blockers. As you know, we can do a captopril renal study. So in most of our cases, that we give you that to try to identify renovascular hypertension, but a lot of your patients are going to come in on these. ACE inhibitors and ARBs are not uncommon cardiac meds. And so if you've got somebody coming in for a renal study that has cardiac problems, they may be on ACE inhibitors. And basically, it does decrease the sensitivity of a study. Iodinated contrast agents, if they've had a CT scan or whatever, they are known to have a short-term decrease in renal function. So if they had an iodinated study 6 months ago, you probably won't see the effects of it. But if they had it yesterday as part of the workup of whatever you're dealing with, you're going to see a decrease in renal function because of the toxicity that iodinated contrast agents provide to the kidney. Diuretics, you know what diuretics do. So basically, this is one of those things where this particular talk is a little challenging because there are a number of things that could impact it. There are a number of things that might impact it, and there are a number of things that have absolutely no impact at all. But the problem is we don't know that. Trying to do a clinical study looking at the effect of drug A on radiopharmaceutical B, it's too small of a population. We're never going to get a statistically significant study that's going to give us all the information that we want. And so a lot of this stuff is basically it's a word of mouth type of thing. And so at this point in time, anytime you see something that looks funny, going back to the medication list and putting that as a possibility is something that should be done. And, you try to rule out what is and what is not a candidate for that. But when it comes down to it, if you can't rule it out, it has to be considered as an option. But I know you guys have a lot of things going on. It's not easy to do that. I think it's key for you guys to become familiar with a patient's medical profile. You basically don't have to be an expert in the drugs, but you should be able to get that information from the patients. If you have any questions, you can always call the hospital pharmacist or your radio pharmacist and try to figure out what's going on. But basically, if you don't have a list, you're going to shortchange yourself when it comes to trying to evaluate this. And then again, if anything abnormal comes up that you find during your work world, if you think it might be a potential drug interaction, publish it. I mean, it's a case study. It's a one-page document. You don't have to do anything fancy, and you don't have to do a lot of statistical evaluation because this is what you saw. But if you see it and hospital B sees it and C and C, D and E and F and G and H, and all of a sudden I've got 20 reports of this, it gives me a lot more credibility to think that maybe that really is a true interaction. Very few people actually report that kind of stuff because their number one response is, well, I have no data to back it up. That's why it's called a case study, because case studies don't require a lot of data to back it up. It's putting it out there so that if anybody else has that same problem, maybe we can all get together and figure out and come up with something that gives us a little bit more credibility. So I encourage you to do that kind of stuff because I think it's important. Luckily for you, this is not going to be a huge problem, but it's something that we need to at least address and talk about and make it available for you. So if you have any questions, please feel free to use your pharmacist, whether it's your nuclear pharmacist or your hospital or institutional pharmacist, because that's their job. That's what they do. And hopefully as you see these kind of things, we can make them a little bit more well known and more available to the rest of the nuclear medicine population.